Great. So you're very welcome. Good evening, Ramadan Kareem. Welcome to the Gulf webinar information session on the University of Warwick MSc in Diabetes Care. We're very delighted to have so many participants tonight. So thank you. I know during Ramadan and just after Iftar, you're just probably tired and you want to spend time with your family. So we'll try and get through this as quick as possible and stay within the hour, if not beneath the hour. So the running order for this evening is that we will start off with the program director, Dr. Colin Kenny. We're delighted to have him here this evening. And then we will have a quick interview with one of our students and existing participants on the program from the Gulf region. So I think it's really important that you hear from someone who's already doing the program and their experiences as a working clinician and doctor in the region. And then I will finish off with the program overview, which is just going through the curriculum, the learning environment, the pricing, and the entry requirements and all the day-to-day need to knows about the program. So you're very welcome here this evening. And without further ado, I'm going to hand you over to Colin.
Well, good evening, everyone. It's lovely to be with you this evening. And I have got a presentation for you this evening. I'm going to share it. Now, hopefully at this stage, you can see my screen. So yes. It's another Irish accent for you this evening. I'm the course leader on the University of Warwick Master's Diabetes Diploma, but I've been a family doctor with an interest in diabetes for well over 30 years now. So I'm going to cover very quickly this evening. I'm going to take an overview of the course. Together we're going to look at the world of diabetes. I'm going to go into some of the course content, and then I'm going to give you a quick update about what's happening in the world of diabetes management. So there's lots of lovely coffee in the Middle East. I wish I was back there enjoying it. But what I would say to you in terms of the flavour of the course, it does follow the IDF, International Diabetes Federation curriculum. We do cover type 1 diabetes, but principally type 2. All our tutors are very experienced, both in practical terms and very well qualified academically. We focus on what's important in your region. We talk about modern management. I'll be coming back to that. Individualizing care, I'll come back to that. And we always have updates on important studies and guidance. It is a very convenient format. It's an online format and it's flexible to work where you can. You can participate from your office or wherever you want to participate from. There are weekly tutorials recorded, as this is, both for interaction and for motivation. So let's look a little bit at the world of diabetes as it strikes us today. And this is a leader from an important journal by Paul Zimmett, a well-respected Canadian diabetologist. It's a couple of years ago now. He says that diabetes and its driver is the largest epidemic in human history. Quite a striking headline, but it certainly would motivate you to think about diabetes. But of course, in the last year, along has come the COVID epidemic as well. And so this has led to the headline, the interaction of two pandemics. And on that subject then, remember, people with well-controlled diabetes are 80% more likely to survive a COVID infection than people with poor or suboptimal blood glucose control. Well, I'm speaking to the Middle East this evening. You can see how striking this increase in the incidence of diabetes will be from 2010 to 2030. Many regions are already at this level of diabetes. And what's been driving this by and large is a global inactivity pandemic. So you can see we in the UK are nothing special, but if you look at Kuwait, for example, where 67% of the population are totally inactive, you can see that's one of the drivers of the diabetes pandemic. So I mentioned incidence there a minute ago. You can see the various countries that you may be from and their incidence. But if you take Qatar, for example, that means 1 in every 5 patients who come into you will be living with diabetes. And that's a lot of the adult population. What are the drivers for this? I've discussed them already, but it's sedentary lifestyles, calorie-laden rich food, higher obesity at a younger level, the need for a culturally sensitive approach to diabetes. National budgets are looking at this. This is having a very big impact on healthcare budgets. And also, of course, all these governments I'm showing are all looking at ways to prevent this diabetes epidemic getting worse. Now, as Rebecca was saying, we're just 10 days into the holy month of Ramadan. I just want to flag up at this stage that, of course, we cover Ramadan on our course in Module 6. We have a full week devoted to it. I just want to flag up that this is the latest Ramadan guidance published last month. And the IDF take this subject very seriously, as does the Diabetes and Ramadan International Alliance. These guidelines are well worth getting. Just to paraphrase them, important to do a pre-Ramadan assessment with people who intend to fast. Healthcare professionals need to be positioned to support people in their fasting. Remember, metformin, short-acting insulin analogs, SUs, and insulin all will need adjustments to dose or timing to reduce the risk of hypoglycemia, which is the big risk in Ramadan. But other therapies do not have the same risk and might be more preferable during Ramadan. Very quickly then, when to break a fast. If you've got symptoms of hypoglycemia, hyperglycemia or dehydration, if you've got an intercurrent severe illness, a blood glucose is either less than 3.9 or 70 or greater than 16.6 or 300. And then if you are on insulin and sulfonylureas and your blood glucose is less than 70 at Suhar, you should also break your fast as well. So key course content of our diabetes course. Well, there's a lot of sand in the Middle East, and we tell you how to make the diagnosis of diabetes. It is a line in the sand at 48 or 6.5%, and we tell you the reasons for that line in the sand. We follow contemporary guidance, and this is the latest ADA standards of care. There are other guidances we follow, such as NICE or SIGN, but they've fallen a little behind the ADA because the ADA revise their guidance, their evidence-based guidance, every year at the turn of the year. So we cover that in Module 2. Of course, we tell you how both the traditional drugs work and also the place for the new and emerging agents. And of course, we devote time to the injectables, insulin and GLP-1s. I know that insulin is a big no-no for many people, but we help to tell you how to use it appropriately and give you guidance on the best insulins and the best use. Naturally, in a course like this, as you would expect, we tell you where the various agents work. This is a complex slide. I'm not going to go into it, but it's just to flag up that we go into detail both on the drugs available and where they work. Now, targets is a controversial subject. Different organizations have different targets. Our ethos would be that we tend to base our targets on individual patient characteristics, preferences, potential side effects, and costs. Would be NICE and SIDE guidance, as it would be ADA guidance as well. So the targets are moving targets. We like to help people set goals for their diabetes in that respect. We start at what the problem means for them. We develop a collaborative goal and we validate their goal and plan. So our ethos would be no decision about me without me. And that's what should inform patient choice. The need for an expert patient should be very clear cut. People living with diabetes spend 3 hours a year with a healthcare professional on average. For the remaining 8,757 hours, they have to manage this complicated condition themselves, and that's why we seek to empower them. We're very careful with language. If I'd been talking to you 15 years ago, I would refer to them as diabetics, when in fact we much prefer the term living with diabetes. So it's free from stigma, we understand, and we're non-judgmental with people living with diabetes. Of course, as you might expect in a course like this, we teach you about emergencies. Everyone knows about hypoglycemia and hyperglycemia, the difference between these symptoms. We go into a great deal of detail in this throughout the course. But it's also worth remembering there's other emergencies. So here's a 67-year-old. You might see them tomorrow in your treatment room. The nurse might call you down to see them. You might be very interested in that foot. I think you'd wonder about that callus that's pre-existing. I think you'd think that that's a very red looking foot. It's probably warm. And then, of course, your interest is drawn to this black area, which is very worrying. I suspect if you started to correct away at that, you would go very deep. You might encounter osteomyelitis. So in fact, whilst I've covered emergencies, this is also an emergency that needs a same-day referral to secondary care. Of course, we cover microvascular complications in Module 4, essentially the opathies, retinopathy, nephropathy, neuropathy. We go into them in great detail. Module 5, I've just finished teaching with the Middle Eastern group. And of course, we look at heart attacks, strokes, and all the problems with the microvascular circulation, which is much worse in the person living with diabetes. We place a big emphasis on albuminuria, how to collect it accurately, because as you know, you may have an EGFR of 48, but if you have a degree of albuminuria, your risk transforms to being very high very quickly. So now a quick update just in the context of diabetes, a little thought about breaking trials. I'm afraid you can't escape COVID this year because I've already mentioned the outcomes are more severe in people with diabetes and metabolic dysfunction itself. But of course, COVID-19 can also precipitate severe metabolic complications such as ketoacidosis and hyperglycemia. Mortality is very significantly related to hyperglycemia if you arrive in hospital. And then the SARS virus itself looks as if it can precipitate type 1 as well, which has led to this headline, which is that they've discovered, of course, that many individuals have gone on to develop type 1 after this viremia from COVID-19. Just worth looking at mortality. It's pretty frightening, I must say, particularly if you've got type 1. Just to return to that, it's the red line. You can see if you're in the later life with type 1, mortality rises very rapidly in people living with diabetes and COVID. Or put another way, this is another study. This time it's telling us diabetes, hypertension, especially cardiovascular disease, are important risk factors for the severity and mortality in COVID-19. And they should be intensively addressed at all times in the management of this infection. Actually, an interesting thing has emerged this year about the SGLT2s. Of course, we talked to them in detail, but this trial is particularly interesting because it shows for the first time that SGLT2s have utility beyond patients living with type 2 diabetes. They have utility in heart failure, and you will probably be seeing them used in heart failure even with somebody who doesn't have diabetes, but particularly if they've got diabetes and heart failure. An exciting trial we all feel is the DIRECT study. Put very simply, if you manage to achieve or encourage a type 2 person with diabetes to lose greater than 10 Ks, they run a very good chance of putting their diabetes into remission. And this has led to this headline: soups and shake diet can reverse diabetes. A little bit dramatic, but certainly a lot of patients have been asking us about this soup and shake diet. Put simply, this is my working lifetime. There's been a cascade of trials in the last 10 years and a lot of new drugs and a lot of new guidance. And of course, we reflect all this in our teaching. This is just some of the trials published in the last wee while. And just to summarize them in this forest prop, very simply, many of the SGLT2s and GLP-1s have proved to be very beneficial, with some of them reducing cardiovascular mortality. And we'll explain to you how that happens. It's had an impact on guidance. We tend to follow, as I mentioned to you, EASD ADA guidance. This was the 2018 guidance, very quickly updated to 2019. And just to explain what that means, this is the 2021 ADA guidance. You can see that it breaks down into people living with diabetes who have cardiovascular disease or not. Then it breaks down as to whether you want to minimize hypoglycemia, promote weight loss, or you have cost-effective implications as well. So put another way, then you can see if they've got high cardiovascular risk, they should get a GLP-1 or SGLT2. Heart failure, they should get an SGLT2. Chronic kidney disease, then an SGLT2 with certain caveats is the preferable agent there. So that's a very quick whiz through the world of diabetes as I see it. Why would you consider the University of Warwick Diploma or Masters? Well, you're delivering diabetes care in a rapidly changing environment. You have a responsibility, I think, to keep up to date in that context. And then the University of Warwick offers you an ideal solution with a comprehensive, convenient way to keep up to date your knowledge and skills. We ensure that your materials are relevant and updated. We work with you to develop your knowledge and skills, and we support you with technology, learning, and motivation. So all our materials have just been updated in the last year, reflecting this guidance. Anyway, folks, sitting is the new smoking. It's maybe time to move about. But at this stage, I thank you for your attention. I will answer any of your queries on the chat. And at this stage, Rebecca, do you want to?
Thank you so much, Colin. That's great. Just before I interview Bashar, who is our current student, and we're so delighted to have her here this evening, I'm just going to do something that we've never done on a webinar before and conduct a quick poll. It should only take around 1 minute because we just want to get a little bit more information and insight as to why you attended this evening. So I'm just going to launch the poll. So can you see that now, everyone? Yes?
Yeah, there, yeah.
Wonderful. So if you don't mind answering, we'll only take around 1 minute or less to get some of your answers as to why you're here this evening. It will really help us. And we've one poll then at the real end of the webinar to just get a little bit more information. We'll do this quite quickly. So thank you for participating, because we think it's important to understand why you're here this evening, taking time out of your very busy schedule. So we've, yeah. Wonderful. That's great, guys. Thank you. So I am going to just, has everybody completed the poll? Yes? You're happy? Great. Thank you. Okay, that's super. Now, that's just a new one. We've never done that before, so thank you for participating. I'll just, now, so without further ado, I want to just talk to Bashar. Bashar, how are you today? Or this evening, should I say? Ramadan Kareem.
Thank you so much, dear. How are you?
I'm good. Thank you for coming on and talking to us this evening.
Sure.
It's really important, I think, that prospective students and clinicians who are thinking of doing the programme, it's all good and well for us to talk about the programme, but it means so much more to hear from someone participating on the programme. So I'm just going to ask you a few quick questions, Bashar, if you don't mind.
Sure.
Excellent.
Yes, of course.
So, Bashar, you are the MSc right now, is that correct?
Yes, I am.
Wonderful. And so when you're doing your, I suppose both, but with the PG Dip to commence with, how did you find it in terms of time commitment and juggling your clinical workload, your family commitments, and then the time commitment for the program?
I have joined the diploma in 2017 and I completed it in 2018. It was a bit of a challenge because the time management, as you have mentioned, because being a full-time clinician with a family commitment as well, it's just about time management, basically. I used to have my laptop, with me all the time. If I have a break between patients, I can log in and do some of the weekly assignments, which helped. And during weekends, if I have off and I don't have duty, I used to log in and complete my work. So it wasn't that bad, it's all about time management, but it's really worth it, at the end of the year. The amount of knowledge I gained, it's huge, to be honest.
Wonderful. And Bashar, if you had to put a number of hours you think you had to dedicate, maybe on a weekly basis, how much do you think you had to give?
For the master, yeah, okay. For the diploma, to be honest, I usually give it 1 hour a day.
Okay. Okay.
Yeah, that was the average. I've been getting closer to the exam, it's more.
Okay.
But usually it's 1 hour a day.
Wonderful. And I think that's pretty manageable. I know it's not easy, but it's pretty manageable, which is good. And can I ask, Bashar, then in terms of the actual technology, the learning environment, how did you find that?
As I mentioned, I have my laptop with me all the time.
Mm-hmm.
And I connect as much as I can, between patients and at home and even at the weekend. So, technology wasn't that difficult. I can also use my phone, but I'm not really happy with the phone because the screen is so small.
Yeah.
I usually prefer my laptop with me all the time.
Yes, no, and I appreciate that. I know, like, it's usable on any, you can do the program on any device, including your mobile, but we do recommend a desktop or laptop because, there's a lot of detailed information. And in terms of the actual canvas and what the interaction or the actual program was like to experience in an online environment, how did you find that?
It's really wonderful. It's very organized. It's handy. You can go back, for the modules, like if you are module 6 and you want to go back to module 4, you can go access it easily, which is very handy during exams. You have to go back and recheck your information if it's okay, if you have missed anything. It's very handy. It's easily. The most important thing is the iHEAD group, because as soon as if I find any difficulty, or I need to get guidance in any way, I usually just send them an email, and then within maximum 48 hours they do respond. Usually they do earlier, because we used to have Ian with us before, and he's wonderful. As soon as I sent him email, he sent me back as soon as he gets it. So that was handy,
That's great.
Terry
is our new Ian.
Don't worry, he's still with us.
Really? Yeah, that's great.
Yeah, Terry is the new program manager for diabetes, and Ian is still with us, so he has not gone.
Great. She's now with us in the masters, so that's great too.
Brilliant. That was my next question. How did you find the support from iHEAD and the University of Warwick staff? So you were happy with that?
I used to be with St. George when I did the diploma.
Yes, of course.
I didn't find any problem, switching, because it's the same team. So I didn't find any problem. The same tutors, the same everything. So it wasn't really a huge jump, between the two universities. So it was fine.
And in terms of interaction with your fellow clinicians and students on the program, how was that?
Yeah, it's hugely, meeting other clinicians in different countries, and then you share your own information back and forth. We have met once now or twice, I believe, since the program started, giving us our supervisors, and we have already shared the WhatsApp numbers, so we can share our information back and forth, which was great.
Are you still in touch with some of the doctors?
Yes,
brilliant. Brilliant. Yes. That's good, because I think a lot of people worry that in an online or distance environment that it would be very isolating or lonely, and you might be.
No. Okay. As soon as we have, I have group locally when I was with the diploma, and we have, although finished 3 years back now, we still communicate and we send cases, and if there's any challenge with anything, they do reply back, which is great. But with the masters now, because most of the group, they're not locally. Yeah. So we have already created a WhatsApp group, which was really handy.
Great. It's good. That's the softer side of a program like that, building that community of doctors and clinicians with kind of like-minded, I suppose, interests. So that's excellent. And Bashar, if I was just to ask you an open-ended question, like what was your favorite part of the program, or, you know, I mean, would you even recommend it to students?
Of course, because I always, have a conversation with Ian. As soon as we have group in Kuwait, he always calls me, so I can come and talk to the group. It's a great program. It's very handy because it's 1 year program. It's not 2 or 3 years. You know, sometimes they are really long programs, make you hesitant to join in. It's 1 year. It's very organized. It answers every difficulty we face in a daily clinic. Before I joined, I thought I knew 40% of diabetes. You know, when I joined in, I have realized that I only know just the tip of the iceberg. But having the course in and being updated and knowing new studies and learning how to search for new studies and being updated all the time gave me confidence. I can prescribe now very confidently. Even the team at work, they come and ask me, which gave me a huge jump even at my level of work, which I really, really recommend it, to be honest.
Thank you so much, Bashar. Thank you so much for your time. You don't have to stay with us. You're very welcome to stay on, but I know it's Ramadan and you might be busy, so I so much appreciate you taking the time out this evening.
Thank you very much. Thanks a million.
See you later. I appreciate it. Take care. Bye.
Bye-bye.
So everyone, I'm just going to run through the actual curriculum now. I'm going to share screen. So can you see my screen? Yes?
Yes, we can see your screen.
Great. Thanks, Terry. So you're very welcome. So just to let you know first, you kind of hear about iHEAD and then the University of Warwick intermittently, and that might be quite confusing for you. So who are iHEAD and how do they relate to the University of Warwick? So we're effectively a medical education technology organisation, and another word for us is an OPM, or an online programme management company. We're an Irish company, but we just hot off the press new news. We've just been acquired by a British company called Cambridge Education Group, and that would be a very old education group in the United Kingdom, established in 1952, and they are delivery of premium quality programs and work with top tier universities in the United Kingdom and in the United States. And they also have a digital wing. So we're delighted to announce we're part of that group now. But iHEAD will function and stay as our own autonomous body. And we specialize in medical education and postgraduate medical education. We work with governments and ministries globally. We work very heavily in the Gulf, throughout all of the Gulf states. We work with Saudi Commission, we work in Qatar, we work in Dubai, we work in Kuwait. And even though you haven't heard about us, we have, I suppose, quite a large footprint in that area. A lot of online technology or online programs from universities also will do marketing, and they'll do photography, or they'll do business, and they deliver all of that. But we specialize in healthcare alone and have done since our foundation. And we were founded by doctors for doctors and clinicians. So we have a huge swathe of full-time and part-time doctors, nurses and other healthcare providers on our subject matter experts and our tutors. So we're very proud of the fact that we're tailored and set up to specifically deal with medical education. We have over 4,000 course completions on our online platform across the globe, many of them in the Gulf. So the University of Warwick, who are they? If you don't know about them, you should, because they are excellent. They're ranked 9th in the United Kingdom. They're 62nd in the world. They have over 14,000 diabetes graduates on their certificate program and also on their postgraduate programs in diabetes over the last 15 years. So it's quite a considerable history and reputation for diabetes education. They're a member of the Russell Group, which is the top research universities in the United Kingdom, essentially equivalent to the Ivy League in the US in terms of output in research. They're world leaders in diabetes education. And just to let you know, it's very, very important that you know that nowhere on your certificate will it say online or distance learning or anything like that. You will get the exact same qualification as if you went to study in the University of Warwick itself. So it's a level 7 on the UK framework is the qualification that you will receive. I'm not going to stop on this slide, but because Colin has covered it extremely well. But as you are all aware that the outcomes for those with metabolic dysfunction and those living with diabetes are very poor in terms of the pandemic. So there is no better time to upskill in this area. I won't go into any more detail because Colin covered it excellently. So I will just go into the programme now. So the Postgraduate Diploma, as Bashir said, is 12 months. Many other online programs in diabetes, it could be 2 years to get the postgraduate diploma and then 3 to 4 years to get the master's in total. So it's very prolonged and it's a long time to commit. So we have 12 months to get the postgraduate diploma and an additional 10 months after that to get the master's. So it's 22 months in total. So that's, you have your full MSc within a 2-year period, and that's exceptional, really. Of course, with that intensive time frame comes a little bit more work, I believe, but I think it's worth it. And I think we have weighed the ability to do the programme, and all of our students are saying that it is excellent to get the qualification in that time frame. We're recognised by local regulators across the globe. We've designed and delivered world-leading diabetes, delivered by world-leading diabetes experts, and delivered on a very advanced medical education platform. It is very important that I point out that this programme was not thrown online because of the pandemic. I know an awful lot of universities have done that in panic, and understandably so, because they can't have face-to-face interaction with their students, and so nearly everything is online at the moment. This program was developed and honed and constantly honed since 2016, specifically for online. And I'm going to show you the platform itself at the end of this presentation so you can get a taste for what is really involved. It's very engaging, it's very interactive, it's got 3D video, it's got hot topics, quizzes, links to Elsevier and journals. And so you get very complex information delivered to you in a very palatable format. And I think that's just the only way to do online education correctly. And that's why we have a team of exemplary engineers, instructional designers, and project managers that put blood, sweat and tears into the creation of this program. And they nuance the case studies for every region that we're in. We don't cut and paste a UK context across all of the world. Everywhere we go, we have local case studies, we have local tutors. In the Gulf, we have excellent tutors like Mohammed Fargali in the DHA and Adil Salim in SEHA, and they really help us hone our knowledge and our delivery for the local environment. So some of the tutors, as I just referenced there, so that's Dr. Colin Kenny, who's our program director. So he's RCGP examiner and past chair of the Primary Care Diabetes Society. We've Dr. Diarmuid Quinlan in Ireland, who's the National Diabetes Lead for the country with the Irish College of General Practitioners. Dr. Stephen Lawrence, who's the Associate Professor in the University of Warwick, and he's advisor for Diabetes UK and Clinical Diabetes Leads in the RCGP. Dr. Pam Brown, Editor-in-Chief in Diabetes in Primary Care and the Primary Care Diabetes Society Steering Committee, and she's part of the NICE programme development. And then, as you can see, we always have local tutors as well, like Mohammed Fargali, Senior Lecturer and Dubai Medical College, Head of Medical Regulation in the DHA. So we're very, very proud of the tutors that we have on this programme, and they're real diabetes experts. And I really like the fact that the vast majority of them are practicing GPs, which means they're not just professors in a university referencing academic journals or trials. They're there at the coalface and they're dealing with patients just like you. And they have a passion for what they're doing in primary care, but not just primary care, secondary and tertiary care as well. But that's one thing, when you get to converse with them, you're conversing with clinicians that are experiencing the same things as yourself. So if we go into semester 1 then of the postgraduate diploma, you start with the core principles of diabetes, of course, epidemiology, diagnosis, screening. And then you go in, well, NCD management, of course, and we then go on to the treatment module 2. It's quite a weighty module. All of our students give us that feedback. And once upon a time, there was insulin, and I suppose lifestyle changes was the go-to panacea for all type 2 and type 1 in terms of their treatment. But now there's so many injectables and orals and so many trials, and it's very, very difficult to navigate that environment as a practicing clinician. And this is what this program teaches you, and it teaches you that one size does not fit all, and that you really have to tailor your treatment to the individual and their needs and their lifestyle. And that's how we must do it in the future. And so that's the treatment module. We also, of course, go into surgery, and we also look at diabetes in children and adolescents in that module 2. Module 3, we do self-management. And self-management is one that the doctors regularly give us, and clinicians on the program regularly give us feedback in terms of how they really changed how they dealt with the individual patient. I suppose, and Colin often says that you might spend 3 hours of the year with that patient, and they have a huge amount of hours after that by themselves to manage their own condition. And from that perspective, it's all about patient empowerment and literacy, and then becoming part of their solution and understanding how they can make their own outcomes and be the ones to affect change in their own clinical outcomes. So it's taking them on that journey, and we do some wonderful motivational interviewing as part of the program. And so the doctors have always said that this has really changed how they interact on a day-to-day basis with their patients, and that's wonderful feedback to get. So next, in course, in terms of semester 2, we look at microvascular complications, and in module 5, it's macrovascular complications. Of course, we do retinopathy, nephropathy, neuropathy, and then we go on to macrovascular, which is your cardiovascular disease, hypertension, etc., and primary and secondary prevention. And then we finalize with special circumstances in the PG DIP. We pay particular attention to religious fasting, particularly Ramadan, when we're working with the Gulf groups, because it's very important, and Colin has covered this as well in terms of hypo and hyperglycemia. But we also look at pregnancy and diabetes, mental health. You may be 3 times more likely to have mental health challenges if you're a patient living with diabetes. And we look at gestational diabetes and diabetes in pregnancy and sport and travel, and all of those special circumstances need to be taken into account when managing a patient living with diabetes. So then, if you're not sick of us and you're not burnt out and you want to continue, we move on to semester 3, which is the MSc. This is an entirely different experience because we have one wonderful module, which is all about research methodologies and really gaining the correct method in terms of how to prepare for your output in your MSc, but it's a lot more individual input, and you're working rather than following learning outcomes. This is your own output. So what we decided to do at iHEAD and the University of Warwick is something that I'm very, very proud of, because it has changed. It's not the usual output from an MSc or master's program. We asked for a 4,000-word research article, and that to be submitted to a local or international medical journal of repute. And the whole purpose of this is that you will get published. We can't promise that, but we will do everything in our power to make sure that you have created a very strong research article with the intention of publication. And we also ask you to do a poster presentation in parallel with that. And that would hopefully, in time when the world wakes up again, that you can present in medical conferences, but in the interim in a virtual environment. So the poster presentation will be essentially a visual outline of your research. So we are looking for that pragmatic output, and the whole benefit of this output is that you will enhance your own CV, your own biography by having done research and hopefully being published. And also you'll be giving back to the research community in diabetes and learning from each other and feeding your knowledge back into that research community, which is circuitous and very, very important for us in iHEAD and the University of Warwick, and you as an individual clinician in raising your own profile. So how does, and I'll go back to the PG dip, because you have to start at the postgraduate diploma before you enter the master's. You can't come into us with another PG dip and then ask for entry directly into the MSc. Unfortunately, we do not give that level of recognition of prior learning. So we start with an intensive online orientation at the beginning of the programme. We have wonderful panel discussion in that orientation with Colin and with Stephen and with the programme leaders. And it's just really exciting to kick off that panel discussion. It gives you a taste of what to expect on the programme. We start on your weekly kind of interaction with iHEAD and with the University of Warwick. We commence the week with the discussion forum. We throw out a discussion topic, which will clearly cover your learning outcomes for the week. And that culminates then in your live tutorial once a week. And that is very unique, and not many other online programs are doing that, where you have a face-to-face live tutorial with your group. And it's not like today when we're just talking at you all the time and it's quite didactic. The live tutorials are extremely discursive, really peer-to-peer, loads of questions to and fro, and it's really just monitored by the tutor rather than you've just been talked at for 1 hour. So the clinicians learn, I think, a lot from each other as well as from the tutor, and I think that's very, very important. And as Bashir said as well, there's so many international input from different countries that it's really nice to see that perspective and how maybe treatments might differ, and medication, even the availability of medication from one region to another. So to get that input from your peers during the live tutorial is invaluable. At the end of each semester, we do have the continuous assessment. The continuous assessment is a 2,000 word essay at the end of each module, should I say. We have the 2,000 word essay. And then at the end of each semester, you have your online examination. So that's proctored online, and it is usually MCQs. So you will have 6 essays, one after each module, and they're 2,000 words, and you'll have 2 sets of exam, one after each semester, to finish the PG dip. And as I said, for the MSc, your output is your 4,000 word research article and your poster presentation. So what does it mean for you? We have very small group sizes. We never, ever go above 30 in any group. And if we do, we start a new group in the region. We take in 150 per intake, 300 students across the world on this particular program. Now we're very, very excited about its success, but you will never know that because you will never be in a group bigger than 30. So you get to know your peers very, very well. And as Bashir said, you set up your own WhatsApp groups. There's loads of interaction, and because the tutorials get to see each other every week, the cameras are always on, and you get to know each other very well. You don't feel isolated. You feel very, very supported. As I said, 6 by 6 week modules, personal commitment, as Bashir said, 7 hours a week. I think that is about average, and coming up to exams and with your submissions, it might be longer, but that would be what we would recommend. And you get, as Bashir said as well, wonderful support from Terry and Ian and the academic affairs team. They're always there to assist, which is excellent, as well as the tutors. So the student experience, 450 students from over 36 countries. I actually think that's 58 countries now. It's growing all the time. We're very proud of that. 100% positive feedback. We do these surveys with our students, but one of the statistics here that I think is really important is 88% student engagement. That is exceptionally high in an online program to get that level of engagement in terms of tutorial attendance and engagement and interaction with the platform. And that speaks volumes about the platform and its quality, but also the individuals who are taking this program. It's 92% pass rate. That's not because we're easy markers. It's because the program, the clinicians and the students on this program themselves are very dedicated. They're thorough professionals and they understand how important it is to engage with this particular program. So the success rates are very, very high. Program impact, as you can see before, is the purple, and these are confidence levels of the clinicians post and pre and post qualification. So after the PG dip, you'll see in terms of prescribing CVD, prevention in type 2 diabetes, initiating GLP-1 agonists, recognizing emotional distress in a young adult with type 1. So you can see the pre and post is quite exceptional. Some of them can go up to nearly 100% and very high after the PG dip. So that's, in terms of program impact and clinical outcomes, that's very, very important. And you can see alumni feedback 3 years after the qualification. The quality of patient care is hugely improved. It's quadrupled. The career has a level of positive impact. Some of our alumni have gone on to be national leads on diabetes committees, one in Kuwait, for example. We have some of our alumni have gone on to set up their own diabetes clinics in their regions, particularly in Dubai. In the United Kingdom, they get to become a GP with a special interest. So there are real career benefits to doing this program and reputational benefits. And just one of those things, and Colin talked about this quite in depth in terms of understanding clinical trials and navigating that area. That can be quite daunting for a clinician, and pre and post is, it's before it was around the 10% mark and afterwards it's in almost 90%. So that confidence level is, in terms of impact, is wonderful. Local recognition. So in Qatar, we've category 2, which attracts 25 CPT hours. In the UAE, in iHEAD, we've category 1, which is 90 credit hours. In Dubai, in the DHA, it's 12 hours of CME. And also in the UAE, though, you can submit your qualification for CME approval in Sharjah and the Northern Emirates. And in the KSA, in the Kingdom, we are in the process of obtaining CME recognition from the Saudi Commission at the moment. But just aside from that, because the University of Warwick is ranked number 10 in the UK and extremely prestigious, we are recognised at a university level on every MOE listing across the world. So there is a huge weight of recognition. And iHEAD works very close with the Ministries of Health across the Gulf. So there's an awful lot of support for this programme. And you may well have got an invitation today from some of our partners in Hamad, in PHCC, in DHA, in SEHA, and the Saudi Commission, because they circulate those invites on our behalf, just because we have such a wonderful relationship with the ministry. So we're very proud of that. So entry requirements. So we evidence of proficiency in the English language. We do not need an IELTS or TOEFL or a documented evidence. We just, if you are taught through the medium of English, or if you can demonstrate to us through a short interview that you have English language proficiency, that's all that is necessary. We do need an employment letter. We do need your transcript, so your MBBS. We need a personal statement of 500 words, and that's essentially to understand your motivation for doing the programme. And we need a photographic ID, and that needs to be an official ID like your licence or your passport. I will be very clear that we have limited places. As I said, we go to 30 in each cohort and then we cut it off, and it's filling very, very quickly in the Gulf. We've already filled one and we're filling the other now. So if you are interested in applying, I would suggest you do that very, very quickly. James or Quiva, if you could put in the apply now and the pay deposit buttons to the chat at some time, that would be wonderful, because you could just go ahead and copy that link now if you wanted to progress straight away, but you will be getting it an email after the event. So the programme fees, the most important slide in the whole presentation, and that is your tuition fee. So it's €7,500, but you can see what it is in Qatari riyals and dinar and Saudi Arabian riyals. So you can see the price across there, but I will be very, very clear that those prices, local prices, are indicative. We charge in euro. We do not charge in local pricing, so they could be subject to currency fluctuations. We did this webinar a month ago, and I was just updating the local currencies for today, and there's a significant change, some good, some bad, but just to let you know that we always charge in euro, so that's very important. But we do have an early bird discount if you do register or pay your deposit to secure your place before the 30th of April. So that's not too far away. If you pay your deposit, you will get a €500 reduction, which is quite significant. And that will give you a reduction, you can see there in blue across the way, but it will be €7,000 instead of €7,500. So to secure your place, you must give us a deposit of €1,000. And then you'll be able to pay later on, but that secures your place on the programme. And then the MSc is €4,500, which you don't have to pay until you're at the MSc stage. So that'll be in 12 months' time. And there are no early birds or reductions on the MSc stage. You can pay in full. You can pay by semester, or you can pay in monthly installments, but there is a cost of credit or a charge for paying in monthly installments, just to let you know. So in the long run, it is cheaper to pay more in advance. So the summary, it's 12-month PG DIP, 10-month MSc. The next intake is on the 23rd of May. And as I said, and I cannot emphasize this strongly enough, we are filling very, very fast, and there's very few places remaining. So if you want to join us, I really suggest that you do apply and pay your deposit as soon as you can. But there is a softer side of this program, and it is, as Bashir alluded to, we have fun, we have great interaction. The tutors are just such professionals, but they're also very down to earth and very likable. And I suppose people like Terry and Ian and our academic affairs team, who will guide you and mentor you and make sure you're well looked after. You will have a wonderful experience on this program, and that I can guarantee. So before I head over to questions, I'm going to end that show there. I'm going to stop share for a second. And what I'm going to do, guys, is I'm going to do one more poll, if you don't mind. And that is just to ascertain a little bit more about why you are here today and why you registered for the webinar. So that poll is launching now. So if you could answer the poll, I'd really appreciate it. It'll just give us a little bit more insight into your motivations for attending today. So that'd be great. Just give it a few more seconds. For 41% have filled it out so far, which is great. If we can get a few more, it'd be brilliant. It's just very interesting and good for us to understand your motivations for being here today, the best way to contact you, and if you wanted to contact you by phone in the next while, just because we understand that you're very busy clinicians. So if you can give us more guidance on why you attended, when you would like to start, and how to contact you, we can make sure that you get the best service and the best after webinar follow-up that we can possibly give you. So I'll just run it for another few seconds, and then we will stop. That's great. Just very quickly after this, before we go to Q&A, I'm just going to give you a slight sample of the actual learning environment. because it's one thing to tell you that this learning environment is exceptional, but it's another thing to see it. And I think it's really important that you just get a little taste for what your day-to-day interaction on the technology would be like and what you would experience as part of the program. So we're at 61% on the poll voting. Wonderful. We're getting there. Thank you very much for participating. So I'll give it a few more seconds and then I'll just show you Canvas, which is our online platform. And then we'll open to Q&A. But I'm conscious you're just after iftar, you're probably exhausted, so I'll try and be as quick as possible. Thank you so much. I'll end the poll there. Wonderful. Super. So thank you for that. That's great. Now, guys, what I'm going to do is just, I'm going to share screen again for a second. Here we go. And I'm just going to bring you into our learning environment. So when you first log in, you first become a student, this is the screen that you will see. So this is Postgraduate Diploma. And if you see here, you will see these are the student orientation. And these are then the different modules. So let's just say if we go into Microvascular, which is one of my favorite, and you go into, I'm such a nerd. So if you go into retinopathy, I love this because I think it's a wonderful module. You'll see, this is what you'll see that week. So the week of retinopathy, you'll get your full view of your learning outcomes and what to expect for the week. You have these interactive accordions with information and links to the WHO and different articles, for example, you can see there your sources. So that's like where you see patients and the impact of reduced sight. So things are clickable. You will see reflective journal task, for example. If I go to the next page, you're asked quizzes, interactive quizzes all the time. You're not graded on these or anything. So what percentage of patients with type 2 diabetes have diabetic retinopathy at diagnosis? So yes, correct. I'm not usually correct. I'm not a doctor. But it's good to see that. So you get these interactive quizzes all the way around us, nicely reinforcing information, loads of imagery. So you're looking at the anatomy of the eye there, another quiz, which of the following is true about the retina? The retina contains rods, cones, and cells, correct. There's a whole video there on the retina. We look at just more imagery. This is clickable. So you see blood vessels in the eye. So you see the level of interactivity there. This is a video describes diabetic retinopathy. So if I press this for a minute.
Diabetic retinopathy is a common microvascular complication of diabetes. Diabetic retinopathy results from damage to small blood vessels of the retina.
So this is what we are all about. Case studies, interactivity, quizzes, links to amazing journals, recommended reading, you'll see there. So it's all very palatable. It's all very interactive. And if I just show you another one for a minute, I like this one too. Where is that? I have it open, I think. I thought I did. Yes, here we go. So we're looking at essentially how to identify and diagnose different types of diabetes. If you look here, you'll have loads of different cases below. You'll have a case study of Hugo, a little kid, and he's 10 years old. You look at his weight and his age and his blood glucose, Lucia, her BMI, her fast, so you've all these different case studies, for example. And so it's all about diagnosis, all these different cases from different parts of the world. And this is what I love as well. This is a decision-based scenario. So this is like a cartoon.
Review the goal for this scenario and then get started.
So this is all about learning in a really interactive way. So Arun attends a primary care clinic for a routine medical examination as directed by his employer. Arun is a 47-year-old male originally from Kerala in India. He tells you what he is a smoker. So you go through all of this information. You have his weight, his BMI, routine testing, further history. And then you get to make decisions based on your knowledge. How far or how many diabetes risk factors does Arun have? I'll say 5. Correct. I'm just guessing. Again, I swear I'm just guessing. But then if I said 2, it'll tell me I'm wrong. And so these are other examples of how we really try and make our learning as interactive and palatable and enjoyable as possible. So I'll stop there because I've been going on a lot, and I'll open to Q&A if you have any other questions, particularly for Colin. Anything you would like to ask. Is there anything on the chat, James, that has been particularly that you'd like to open, or a salient question that we should read out?
No, there isn't, Rebecca. The chat's been quite quiet today, so I think you've probably covered most things. But if anyone does have any questions, you can pop them into that chat now and we'll get them answered for you.
I've either covered everything or I've put everybody to sleep, one thing or another. Wonderful. Well, that's the first. We usually have a lot of questions. Mustafa, that's a good question. Are there any samples available to practice the MCQs? Not really for the test, but what we do have is an open source section, which is the retinopathy section that we can give to you. You can log in and register free of charge, and you can sample that section for yourself, which is, we can send that out to you by link if anybody wants it. So that's one way for you to get to taste the online environment for yourself and take your time to go through it. So we don't really give the MCQs or the exams there, but we can give you a sample of the program.
Mustafa, we also do a mock MCQ examination because it's supervised by a group called Examity, and they proctor your exam. So it's there's certainly MCQs in the material, but also we let you have a mock MCQ exam just to get the feeling of that. And many people value that because being proctored online is usually a new experience for them. But yet it's the way we do it, and it's the way the University of Warwick approve it. Remember though, Mustafa, it's only 30% of the overall examinations that we do. Most of it is for written essays. We have extensive guidance on how to write essays, how to approach essays, and we'll certainly talk you through all that, because we feel an important part of this diploma is return to learning and the learning environment and being able to express yourself in written form as well, if that helps you, Mustafa.
Just to let you know, everyone, we have recorded this session and we will be sending it out to you by email. The email will go out to you tomorrow. You should receive it. And you will also receive in that email a button to apply and a button to pay your deposit. I will just say it one more time, it is filling very fast. So if you do want to secure a place in May, I do suggest that you pay your deposit as soon as humanly possible, and apply with all your documentation as soon as you can. So Adnan has a question there, Colin. Inpatient settings, yes.
And I've got to say it is based for, primary care physicians. We certainly cover the emergencies. We cover the things that you need to have, as I mentioned to you, a same-day referral to hospital. We certainly cover insulin regimes in detail that would be applicable to a hospital setting. But a lot of what we cover is how a family physician or a practice nurse would approach the care of somebody living with diabetes and all aspects of that. So the inpatient medicine is a complex area. We do touch on it, but most of it is on the on an outpatient setting.
Are there any more questions, everyone?
I'll take that one, Saravanas, you heard from Bashir that it's very variable about the length of time that you need to spend. But most people are recommending between 5 and 10 hours set aside per week. It varies, of course, because some weeks you're doing weeks you're doing essays. Every week you're giving some written feedback. I think Bashir gave us a little hint there that she approached it like eating the elephant, a little bit at a time. And I think that's probably the way to look at it. But you do need to devote some time to this because, as Rebecca has told you, this is a prestigious diploma. The University of Warwick don't give out their diplomas willy-nilly, and therefore you do need to commit some time to it. And of course, every week there's an hour set aside for the tutorial that's taught face-to-face.
Thanks, Colin. I hope there are no vegetarians with us eating elephants.
Sorry about that, now.
I'm only kidding. I think that's most of the questions covered. So you will receive the email with the recording, the deposit, and the apply now. And you will receive a reach out from our education advisors, usually by phone, but you may have a preference stipulated in the poll today. So we will review that. But they will try and contact you by phone and answer any individual questions you might have. Thank you so much for your time, everyone. It was a pleasure. And Ramadan Kareem, I know it's a tough time of the year to be asking you to participate in a webinar, so we really appreciate your attendance this evening. Thank you so much. Take care.
Bye-bye, everyone.